welcome everyone. Sorry, I have a dual microphone here. So welcome everyone. I'm glad and happy to be here with once again with all of you with the ERN webinars, especially from our GUARD-Heart group, and I'm more than happy to be surrounded by such a great group of experts. And here we have today, Cristina Basso and Bo Winkel, and we will have our junior representative, Andrea Greco, that will present the case. We wanted to talk about the importance of preventing and improving outcomes in sudden cardiac arrest, and we thought that it was very interesting from the very the beginning to start with one everyday case, and from then on to talk about that. So, Andrea, the floor is yours. Thank you.
So thank you very much, Georgia, for the introduction. Good afternoon to everyone. I think you can see my slides. So today we are going to talk about a very interesting topic on preventing and improving outcome in sudden cardiac arrest. And to make an introduction to these topics, as Georgia says, we can start with a clinical case. So we are looking at the case of a 27 years old, 15 years old, sorry, previously healthy male, collapsed during a soccer game. He reported dizziness and voluntarily left the field, and shortly after he experienced nausea and vomiting, followed by approximately 30 seconds later by a sudden loss of consciousness. So basic CPR was initiated about 1 minute after his collapse, and an AED was connected 2 minutes after CPR began, and he detected a shockable rhythm, and the first defibrillation was administered minute 5, successfully achieved return to a spontaneous circulation. However, within seconds, the patient experienced a second cardiac arrest, so basic CPR was resumed. And once the EMS took over, the patient developed a documented episode of torsade point requiring pharmacological treatment with amiodarone, magnesium sulfate, and a second defibrillation that successfully restoring the sinus rhythm. Upon the arrival at the emergency department, the patient was stable, intubated and connected to a mechanical ventilation. Transient mydriasis followed by left side clonic seizures that became generalized seizure aborted with midazolam, and the toxic causes, including medication and substances, were ruled out. So this is the 12-lead ECG post-resuscitation that showed a sinus rhythm with, as you can see, a ST segment depression in inferior leads and precordial leads, suggestive of a transient myocardial ischemia or global hypoperfusion. So a cranial CT scan was performed to assess for hypoxic ischemic injury or intracranial pathology, and the results were completely normal. This is the ECG on the second day of admission. That is an ECG that normalized, showing only a mild repolarization changing in the inferior leads, which are common in athletes. So given the clinical scenario, we started an extensive evaluation to identify the underlying causes. So we realized a cardiac MRI, that show a normal ventricular systolic function, normal volumes, and non-structural abnormalities. An EP study was conducted with a baseline ECG and QTC that were normal. No arrhythmias were induced during the programmed ventricular stimulation, and isoprotenolone infusion showed no pathological QTC prolongation, and the Ashman test was negative for Brugada syndrome type 1 pattern. So during the same procedure, a coronary angiography was performed, which showed normal coronary anatomy and flow. And in the absence of a clear diagnosis, but in the context of a sudden cardiac arrest, we decide to implant a single chamber ICD as secondary prevention. So looking to the family history, we noticed several red flags like two maternal uncles that die suddenly, a maternal cousin has epilepsy, and a maternal aunt had a third trimester miscarriage. So during the follow-up, this patient underwent a treadmill stress test, several treadmill stress tests, and the findings were completely normal, including the baseline ECG, at peak exercise, and during the recovery, as well as the QTC interval in this test. So let's take a look to the genetic results of this patient. So the patient was found to carry 4 genetic variants, and this is the variants. And to make a resume, according to the updated ACMG guidelines, HCN2 and MYPN were classified as VUS or likely benign. CTNNA3 deletion remains a VUS, which limited the evidence supporting a gene disease link. And GAA deletion is considered an incidental carrier finding with no clinical relevance in heterozygosis. So no pathogenic mutation has been identified to explain the phenotype of this patient. This is the family pedigree chart of this family that reveals multiple carriers of the above-mentioned mutation on the maternal side. In contrast, in the paternal family history, shows no cases of sudden cardiac death and no identified genetic mutation. So what about this patient after 8 years of follow-up? He had no cardiac events recorded, no ICD shocks delivered, no episode of SVT, VT, or VF documented. The annual follow-up tests were normal. The genetic testing, including the reanalysis and variant reclassification, remain inconclusive. So in this case, the patient meets the criteria for an idiopathic ventricular fibrillation. What is an idiopathic ventricular fibrillation? This is an exclusion diagnosis, as we can see, defined as a ventricular fibrillation in the absence of structural heart disease, channelopathies, or metabolic triggers, despite a thorough evaluation. Although rare, it remains an important cause of sudden cardiac death in young individuals, and we know that survivors are considered at high risk for recurrence. And for this reason, an ICD implantation is the standard of care for secondary prevention. So lifelong follow-up is essential in this patient, as some patients may develop cardiomyopathies, genetic syndromes, or subtle structural changes over time. So this reflects the evolving nature of this diagnosis. So in conclusion, that case remembers us, once again, how important is the automated external defibrillators in sports that could be a real lifesaver on the field. So thank you very much.
Thank you. Thank you, Andrea. I think this is, all of us have one of these cases, and all of us have these frustrations and these questioning in whether if we are doing the things correctly. So I think that Christina will enlighten us for some further details. By the way, before Christina enters, I have the pleasure to have Elena Arbelo with me, and so Elena, if you want to introduce Christina.
Sorry for the delay. I had some family issues, but yes, this is a fantastic webinar. I'm happy to have all these speakers. So thank you. So now we would like to have Christina Basso share her experience on the best practices and how to evaluate what the diagnostic workup in sudden cardiac death should be. So thank you, Christina, for being here.
You see my slides? Good. So
yes.
I'm not talking about prevention of sudden death, of course, in strict terms, because I'm talking about the diagnostic workup in sudden cardiac death decedents, but this is also important to prevent other events. So this is the famous Meyerburg slide demonstrating which are the substrates which were not present, by the way, in the case just presented by Andrea Greco, because it was idiopathic ventricular fibrillation, but idiopathic ventricular fibrillation is existing, particularly in adolescents and young adults. But when you move along the age of the population, you see that there is an increased incidence of sudden death, and the cause usually is ischemic heart disease after 40 years of age. Before, you have a wide spectrum of disease that you need to investigate at postmortem and possibly in vivo in aborted sudden cardiac arrest. So the importance of autopsy has been stressed in many documents. This is the document by the European Society of Cardiology, the guideline in the management of patients with ventricular arrhythmias and prevention of sudden cardiac death. You see that a comprehensive autopsy is recommended, ideally in all cases of unexpected sudden death, and always in those under the age of 50, and the class is 1B. Then there was a document of the Genetic Society together with the cardiologists and with pathologists, the European recommendation integrated genetic test into multidisciplinary management of sudden cardiac death. But again, you see that at the beginning of the flow chart, there is the medical, legal, and or medical autopsy, because you really need to understand whether a cardiac disease is there, sudden cardiac death, or generally speaking, sudden death without a structural heart disease. If it's cardiac, whether it's structural or with normal heart, and then you need to proceed on with all the rest, including family screening and genetic test. And then this concept has been very well underlined in the recent document of the Lancet Commission to reduce the global burden of sudden cardiac death. You see that among the 10 commandments in this key message of the article, number 9 is saying that you need to strengthen current autopsy practice with increased availability and practice in suspected sudden cardiac death, especially in people less than 50 years, because this can provide crucial data for at-risk families, and focus research on partial autopsy substitutes is also important, particularly in some geographic area, also due to religious issues. Why autopsy is important and a well-conducted autopsy is important? Because sudden death is not always cardiac. This is the first very important message. According to the data provided by the San Francisco County, you see that among 30% of the cases can be, more than 30% of the cases can be non-cardiac, including neurological, pulmonary, infective, vascular, gastrointestinal, or acute overdose. So first you need to say whether sudden death is cardiac or non-cardiac in origin. And this is only if you perform a complete autopsy. Then you can have the autopsy, excluding the non-cardiac cause, and then you can have a sudden cardiac death non-inherited, for instance, a thrombosis, plaque rupture, could be, of course, the risk factor inherited, but the disease per se is not inherited, possibly inherited, or sudden arrhythmic death syndrome unexplained, like, by the way, in the case just presented of aborted sudden death. According to this, also the Pathologists Association, both in America, in US, and in Europe, decided to have a protocol for autopsy investigation, because first you need to perform the autopsy, but then the quality of the autopsy is very important, like for other technique, because not all autopsies are the same. So you need to have a minimum of protocol to be sure that you are investigating carefully the coronary arteries, the myocardium, the valves, all the structure of the heart, and sometimes including also the conduction system. Then, besides growth histology, toxicology is mandatory in all cases of sudden death, particularly in young people, but not only young people. But the blood sample for genetics is important, and family investigation should go together with genetic screening. This is very simple, but it seems simple, but is not performed in every case of sudden death. Not just one section, because the disease can be very focal, can be regional, can be apical, basal. So you need to perform multiple sections of the heart to look carefully to the myocardium. You need a multiple histological sample to exclude focal myocardial disease. You need to look carefully to all sections along the coronary artery disease, because the coronary plaque can be just one segment, a few millimeters long, and then you miss the diagnosis if you miss to study completely the coronary tree. And this is explained in part the wide variation when you compare different studies of sudden death in the young. in terms of substrate. In some series, normal heart is not existing. In some series is reaching 50% of the series. Some disease in some series are 1/3 of the causes, like hypertrophic cardiomyopathy. In other series is not existing. So which are the criteria and which is the protocol applied in different series published in the literature? This is just an example I always present. It was an athlete, very famous athlete in Italy. The first forensic autopsy judged the heart as a normal heart, and then we added further section, and we demonstrated that there was a scar in one of these sections, not present in the other one, just in this section, you see, here is normal, here is normal, here is normal, and then this section at histology demonstrated classical fibrofatty replacement. So the heart was judged as normal at first sight and then was not anymore normal because there was a substrate there that is not easy to catch if you perform limited sample at histology. So this is my always say joke that my approach to sudden death investigation is to want to look with my eyes and to touch with my hands because I don't trust even myself. So this is our experience in the Veneto region, northeast of Italy. 1/3, almost 1/3 is unexplained, is idiopathic ventricular fibrillation. We don't find an explanation even at postmortem, even at histology, and then all the other causes with a wide distribution. There is a problem approaching the sudden death because there is a gray zone between normal and pathological findings. For instance, many cases are labeled as arrhythmogenic cardiomyopathy, but they are not arrhythmogenic cardiomyopathy. I just saw a case today. It's a simple fat infiltration of the right ventricular free wall, which is not a disease. You can have, a compensatory hypertrophy, physiological hypertrophy, like particularly in athletic population. You can have focal disarray without hypertrophy. This is not pathological, it's not diagnostic for hypertrophic cardiomyopathy. You can have focal inflammation, which is not focal myocarditis. And then there is a big issue of aborted sudden death or prolonged resuscitation maneuvers that you have a lot of ischemic injury in the myocardium. It's not easy to understand whether this is primary or secondary. Again, pitfall, diagnostic pitfall for the pathology and the forensic. This CND is not a pathological heart, it's just a case of obesity with a lot of fatty tissue in the pericardium, some fat infiltration in the underlying myocardium without fibrosis and with the normal myocytes. Instead, A and B is a classical arrhythmogenic cardiomyopathy with wall thinning, disappearance of the myocardium, fibrofatty replacement, and abnormal cardiac myocytes. And sometimes CND is labeled as arrhythmogenic cardiomyopathy with all the consequences on the family members in terms of family screening and genetic screening. So when you, as pathology, have to formulate a diagnosis, we should identify a clear pathological cause at the postmortem. If it's not present, we have to admit that the heart is normal. We have not to find in 100% of the cases a pathological report positive for something, because this can be an issue. And again, we need to recognize that there are different degrees of certainty in defining the cause and effect relationship between the substrate and the sudden death event. The common substrate of sudden cardiac death have been classified as certain, highly probable, or uncertain, and we provide a few examples. And in the probable, especially in the uncertain category, each case should be considered on its individual merits. And then, as I already mentioned, that there are gray zones, particularly in myocardial disease. Just few examples is a complicated table coming from the pathology paper. Coronary artery disease. If you have occlusion, dissection, thrombosis, there is no doubt that this is the cause of sudden death. Myocardial disease with diffuse myocarditis, severe myocarditis, no doubt. But if there is coronary artery disease without lumen occlusion, stenosis, critical stenosis more than 75%, is it really 100% the cause of sudden death, or we can judge this as highly probable and we leave open the door to other possible interpretation? So this is an important issue, but because the substrate is not to cure the cause of sudden death. This is a classical example. When you have a cardiac tamponade, I mean, nobody would doubt that this is the cause of sudden death, cardiac rupture, or aortic dissection. But on the right side, this critical stenosis with still a lumen, not thrombosis, are we sure that this is a subset sudden death, or there could be something else? And then the big issue of conduction system investigation, which is quite popular among forensic. Always they want to perform a conduction system. They found something, there's some fibrosis, some dispersion, like in this case, but I would never provide a report saying that this is the cause of sudden death. It's just a descriptive report, but open to every interpretation. Myocardial bridge is again another big issue. Focal inflammation, just one foci in a full heart. I provide a description, but could be channelopathies, could be something else, and we really need to leave open the door. So this important message that has been already supported by the School of St. George Hospital, demonstrated that there are many findings of uncertain significance and the potential for erroneous interpretation. So one thing is to find the substance, and one thing is to say that this is the cause of sudden death. When you have some doubt, for everything is the same for CMR, for CT scan, for ECG electrocardiographic reading. The best practice is that you refer the examination to an expert center. This is also for autopsy investigation and morphological investigation of the heart. In this case, there are referral centers to study the heart, to review the gross examination, to review the picture, and to review the histological slides. And this is also a recommendation coming from the sudden death Lancet Commission paper, a recommendation for management of decedents, survivors and relatives, establish a minimal standard of protocol and tissue and fluid sampling to ensure the quality of the autopsy investigation, which means a gold standard autopsy. To ensure fluidity, current laboratory should be promoted for the pathological diagnosis of disease in people who have sudden cardiac death, including the implementation of digital pathology for second opinion. Then, of course, it's important to train young people also in the field of forensic and pathology examination. This is my slide, and thank you for your attention.
Thank you. Thank you, Cristina. Go ahead, Elena.
No, I was going to say the same as you. Thank you. I found it very interesting. I'm sure we'll have lots of interesting discussion points at the end. I'd like to introduce now Bo Winkel. He will be discussing how to improve outcomes in out-of-hospital cardiac arrest and give the excellent experience they have in Denmark. So thank you.
Thank you. I just needed to unmute myself before I share the screen. Okay. Just 2 seconds and I will be ready for this.
Yeah, it's okay.
Okay. Okay, so I hope that you can see my...
Yes, we can.
Great. Okay. Okay, so thank you very much, and thank you for inviting me for this very, very nice webinar. And I was asked to talk about how to improve outcomes in out-of-hospital cardiac arrest, and with the focus also a little bit on the Danish data, but not solely, obviously. These are my conflicts of interest and not related to this talk. So basically, when we are talking about how to reduce the burden of sudden cardiac death, we have two ways of doing this. We can either prevent the sudden cardiac death or the sudden cardiac arrest for even happening, and then we can be better at doing the resuscitation once the cardiac arrest is there, so that we can hopefully get the person that is in the cardiac arrest resuscitated, so not succumbing to a sudden cardiac death. So those are basically the two possible ways of reducing sudden cardiac death. And we'll start by looking a little bit on the prevention. And in the prevention, I think that what is very important is to understand the sudden cardiac death case and burden. So what is the epidemiology? What are the causes of death? Who is at higher risk of sudden cardiac death? And how to prevent the next death from happening. I will go a little bit more into detail on this. And if we are looking on a nationwide scale and looking at the young, looking at all causes of death throughout the lifespan, you can see that in the young persons, non-natural deaths, so that could be suicides and accidents, are the primary driver of death. And when we are looking in the older populations, it's going to be cancer that is running the causes of death. And obviously, everyone is going to die at some point. But what I want to point to you here is the blue line, which is the sudden cardiac death proportion of all deaths in the given age ranges. And what you can see here is that sudden cardiac death continues to be a very important cause of death throughout the lifespan. So when we're looking at the incidence rates of sudden cardiac death by age, we can see that sudden cardiac death in the young, luckily, is very, very rare occurring. But when we are getting older, from the age of 35 years, we can see that there's a very, very rapid incline, steep incline in the incidence rates of sudden cardiac death. And so this speaks into the fact, obviously, which is also what we know, that sudden cardiac death is getting more abundant with age. So we do know a lot about sudden cardiac death, and we do know a lot about the epidemiology. But when we are looking at populations that might be at risk, it can be a little bit more tricky. So this is an example where we are looking at epilepsy and the risk of death and sudden unexpected death in young people. And again, making use of the sudden cardiac death database and combining it with other data on epilepsy, we can see that epilepsy patients actually have a 16-fold increase of sudden unexpected death. So patients that we do know have an epilepsy diagnosis is by far in a very, very increased risk of succumbing to a sudden and unexpected death. And when we are looking at another population, so this would be the psychiatric population, so patients that have had a previously hospital-based psychiatric treatment, we can see that these patients are having a fourfold increase of sudden cardiac death. So again, we are looking into a subpopulation that is an increased risk. And then when we are looking at diabetes, patients with diabetes, we can see that they have a 7-fold increased risk of sudden cardiac death compared to persons that do not have diabetes. And you can see that it's both type 1 and type 2 diabetes that is driving this increased risk of sudden cardiac death. When we are then looking at risk for medication, we can see that if you're getting a medication that is listed on brugadadrugs.org or brugadadrenic drugs, those to avoid if you have Brugada, you can see that there is a 2-fold increased risk of sudden arrhythmic death syndrome. So those are the cases that are unexplained even after a thorough autopsy and also a negative toxicology, compared to explained sudden cardiac death patients. And when we are looking at QT prolonging drugs, having more than one QT prolonging drug in the bloodstream at the time of your cardiac death, it's with a 3-fold increased risk of that being a SATS case. And so here the SATS cases could speak in favor of an arrhythmic substrate for the sudden death. And when we are looking into the post-mortem toxicology in these patients, this is actually also what we see. So bear in mind that none of these patients have had overdoses. They're just being treated in pharmacological doses. And we can see that these all patients, whether it's SATs or whether it's coronary artery disease or myocarditis, we can see that positive toxicology in these cases is very, very abundant. So probably medication and probably polypharmacy is playing a very big role in many cases where there is an arrhythmic substrate leading to sudden cardiac death. Another point that is very important is that if we do know that we are having a sudden cardiac death case where has been performed an autopsy, maybe even a genetic testing, and we do know that this patient were having an inherited cardiac disease, it's very, very important to do the family workup and to do the genetic testing in the family patients. And it's very important that we here come to the understanding that we need to share those data and we need to share those genetic results across the country, across different regions, because people are moving around. And so it's very important that what we are doing in one part of the country is also translated into the patient's family in the other end of the country. And when we are looking at the relatives and the diagnostic yield in relatives in patients with probable inherited cardiac disease after sudden cardiac death, we can see that there is an 11% yield, 11% of relatives that are being diagnosed with an inherited cardiac disease when we are looking at these relatives, and a borderline diagnosis in a further 11%. So this is very, very important to do, because if we are seeing and understanding the disease and we can find relatives with this disease, then we are upping our chances to actually reduce the burden of sudden cardiac death in that particular family. So when we are looking at these inherited cardiac diseases, we can see throughout 20 years that the number of patients that are receiving inherited cardiac disease diagnosis are rapidly increasing. This is from 20 years from Denmark. And what you can see is that the incidence rate of inherited cardiac diseases has increased from 5 to almost 40. And you can see that it's both cardiomyopathies, but also primary arrhythmias that are driving this trends. And that is very nice. And that also speaks very much into what has been shown by other people. When we are looking at the cardiac arrest, this is a very nice review from CN Seng. This is very important to look at the patient, whether or not they are resuscitated or not, and whether they are experiencing a sudden cardiac death, a presumed sudden cardiac death, or maybe even a non-cardiac sudden death. So getting an idea whether or not this is cardiac and whether or not this is inherited is very, very important. Okay, so I want to now turn a little bit into the resuscitation for the remainder of this talk. And what I want to show you is how to optimize the resuscitation in order to heighten the survival rates once you're actually having a sudden cardiac arrest. And what is very important here is obviously, as we all know, the critical timeline, the immediate CPR and the prompt AED use, but also to understand why not all patients are resuscitated. And I will show you a little bit of some of the initiatives that can help you getting higher survival rates. So this again is from Denmark, where for 20 years we've had a continuous work on raising a number of out of hospital cardiac arrest patients where CPR is performed by bystanders. So immediately when there is a cardiac arrest, then there will be bystanders that are performing the CPR. And some of the things that we are doing is that CPR training is performed in schools. There is a mandatory CPR training when you're obtaining a driving license, and many people, most people, are getting a driving license at some point. Then we do have the Heart Runners app, and we are having many awareness campaigns. And this is just something that we can do. But what we can see is that CPR has risen from about 20% of cases to now more than 80% of all cases of cardiac arrest in the community in Denmark. And then when we are looking at AEDs, the number of AEDs have risen from 0 to more than 25,000 now. And these AEDs are all registered in the same app. So if you're just opening your phone, you can actually see exactly to the point where the nearest AED is. And what is very important is not only to have these AEDs inside the bank, but outside the bank, so that this AED is available 24/7, because the cardiac arrest obviously does not respect whether or not there's a closed door between you and the AED. So they need to be accessible 24/7. Putting that together with the volunteer responders, heart runners system that I just touched upon, we have more than 160,000 people in Denmark now registered for volunteer responders. So whenever there is a cardiac arrest, up to 20 volunteer responders are alerted and asked if they can help for this supposed cardiac arrest within their proximity. And they will then be directed to the cardiac arrest, and there will be one or two that are being asked to run for an AED along the way. And with this, it has given us now numbers that are showing that 30% of all cardiac arrest patients with a shockable rhythm receive shock from an AED even before the ambulance arrives. So that means that we now have prompt CPR and prompt AED even before the ambulance arrives, that has maybe 5 or 6 minutes response time. And this is something that can be very life-saving. And actually, it has been showing that we are getting the survival rates very much higher in Denmark, and now to about 25% that are being resuscitated, and about 10 to 14% that are being discharged alive in Denmark. So for the last bit here, I just want to touch upon the importance of knowing the cause of the death. When we are looking at these incidence rates, it's very important to understand that that sudden cardiac death, at least in Denmark, is declining, and it could be owing to all that I have been showing before. But what we can see from the numbers is that for 20 years we've had an annual decline in sudden cardiac death of more than 3%, which corresponds to a 49% reduction during 20 years. So now we're seeing less sudden cardiac death in Denmark as we did previously. But what is driving this is actually those that are witnessed. So it's the witness cases that are driving this decline in sudden cardiac death, while for the unwitnessed cases, and that would be the blue line, you can see that there's been absolutely no change. So we need to think in additional ways to further prevent sudden cardiac death. And I showed you this one in the beginning, but what we need to now focus is the unwitnessed cases, and maybe the near-term prevention where warning symptoms or connected devices or artificial intelligence maybe in the future can help us even more in further reducing the burden of sudden cardiac death. So in conclusion, some drugs and certain diseases might put you at increased risk of sudden cardiac death. We know that. And the overall as sudden cardiac death incidence rates are declining, at least in Denmark, and probably it will be because of these things that we can do with more CPR and prompt AED use that is effective in increasing survival rates in witnessed cardiac arrest cases. But we do have a problem with the unwitnessed cases that remain unchanged over time. And there is definitely a lot of potential to further reduce the burden of out-of-hospital cardiac arrest in the future. Thank you very much.
Thank you, Bo. I think it's super interesting, and I think that this has not it's not all yet, you know. There's many things that we will learn in the following years, that we have learned a lot. There's much we have known since those first cases, but even though we have those unknowns and keep having so many doubts, so I wanted to ask Andrea, after what it has been said so far, do you think that maybe we would have done things in a different way? Sometimes it's something that we may think after 8 years in your case, that there has been no shocks, no arrhythmias, nothing else. What is your point of view on this?
Yeah, probably yes. Like always, no, we can do something better, no? Probably. I think that in this case, in particular, in this case, when you have, sudden cardiac arrest with ventricular fibrillation in the ECG, evaluated by the emergency physician, so it's impossible not to put an ICD noise. I think is a thing that is impossible to not to do. So probably in our case, there is no genetics. There is a family with something in the history with some sudden death. We don't know if cardiac death, but with some sudden death. Probably in the future, we don't know if there is something new in the genetics or in the patient. But 8 years of follow-up are a lot.
May I ask you something? Did you study the family, and did you find anything in the family?
No, we studied the family with this genetic mutation. For this genetic mutation, in some of the family patient with a large genetic evaluation, without anything in the family, in the maternal part of the family. In the paternal part of the family, there is nothing in the history, nothing in the genetic, nothing, completely nothing. It's the only patient.
I think this is a very interesting point, and I think Christina wants to comment on this, because usually you have families that help you guide the phenotype and the other way around. And the question, and I would like the opinion of the panel, how would you manage the follow-up of these patients? Of course, you need to follow these patients, but what would you do with the family? Would you see them regularly or not? So Christina, go ahead. You were going to say something.
Of course, my comment was about the case, but because the follow-up now is 7 years, if I remember well.
8 years, yes.
There was no ICD discharge, nothing, no other symptoms. So, and there is an ICD subcutaneous or intra?
No, it's endovascular, normal.
Endovascular. So, did you have the opportunity to perform a new cardiomagnetic resonance or not in this patient? No, because
I really don't remember. Probably not in our center, but probably.
No, the only one was 7 years ago.
Yeah, yes, 7 years ago, yes. But I think
my question is whether in this case, with no discharge, there is any indication to repeat the MR or to remove the ICD. This is open for discussion, not to remove the ICD. Nobody will remove for sure, but to understand what is going on in the heart. I mean, because another possibility could be, low potassium or channel
Yes.
ionic disturbance at the time of the cardiac arrest, something
Yeah.
transient, not chronic, not persistent, but the patient, the guy now has an ICD. So is of course open for the panel discussion, the expert electrophysiologist, but
now, this is my question. So maybe, Bo, you can comment. What type of follow-up do you do with these patients? Do you repeat any test? How often?
Yeah.
How would you do that?
So I think that in my experience, and now we have several hundred idiopathic VF patients and families, and we have done routinely this, that we are doing all the investigations that you did, Andrea. So making a very thorough investigation at the primary event of the patient, making sure that we are not overseeing any diseases, and then also applying the broad genetic testing panel, actually, as you also did. I suppose it was very broad based on what you found.
Yeah.
And then see the first degree relatives, and we do that routinely, and we are putting all that together. Then what I say to the patients and what I say to the family, and this is based on my experience, is that this is most often not an inherited cardiac disease. So if you are having a true idiopathic VF, negative genetic findings, and a negative family history when you do the initial workup, then it's most likely not an inherited cardiac disease. So I would be, with that case, I would be happy to discharge, for instance, the parents after seeing them once, maybe also the siblings after seeing them once. If there are any children, then I would probably repeat and see them a few more times until they reach adolescence. What I would say is that we are very often being a bit surprised by the genetic findings. So the genetic findings can definitely be a game changer, and also when we are looking at the families. I would say that in maybe 10 or 15% of our idiopathic VF families, we find something in the genetics, or we find something in the family, and then of course it's another story. And as for the ICD, in my opinion, I think that we have for our patients, we have 1/3 or maybe 40% of the patients get an ICD discharge within the first 3 or 4 years. But then again, we also see patients that don't receive any ICD shocks until maybe 10 years after. It's very random what is happening. So I would not take out the ICD.
So I have to share. I agree with what you have said. What we usually do is patients, we do a complete workup as you did at baseline. The ICD, of course, you implant it, and it's very difficult to make the decision to explant it. We do genetics, and in fact, as you say, in some cases that we've had revealing findings. So with normal CMRs, we've got PSPs that were likely pathogenic, and then 8 years later, with several shocks in between, I've had patients develop the proper, ARVC or cardiomyopathy. So I think that for the index case, it makes sense to follow up, and I agree with Christina. You need to repeat and reconsider redoing the test periodically. And then I do the same. So if I don't see anything genetic in the family, I do a baseline evaluation of the relatives. If it's normal, I would discharge them, because where you're going to find something, it's really going to be in your index case. And then,
I totally agree. I keep seeing the idiopathic VF patient, and I do regular assessments, and it does not need to be yearly, not at all, but maybe just at some points you need to look at them again and make sure that they all of a sudden you don't have a cardiomyopathy or anything else that have developed over time. So doing the periodically assessment, I think is the right thing to do in the patient.
So may I ask now something to Christina? Christina, I'm really concerned about pathologies worldwide and locally. So I don't think that we can feel comfortable with pathologists, the standard training that a pathologist gets in the average hospital or in the average forensic institution. I think that performing cardiac pathology is quite complex, actually. And of course, as in anything, if you get the proper training, if they come to see you, Christina, and train with you, they'll do it right. But I'm concerned on how can we improve that, because the rate of autopsies where we don't have findings, of where a finding is attributed as causal and it shouldn't be considered causal. And this is going to mark how we manage our patient and the relative. I mean, the disease not, but the patients that we have in the clinic, relatives of this person, is going to be the game changer. So we really rely on you. What are your recommendations, or what are your thoughts?
I mean, the recommendation is we already wrote many documents, and the last one very important of the last Southern Cardiac Commission. The message is there. This is a really political issue. In the right, I mean, meaning of the term. And what we need as pathologists is your support, because the cardiologist should push for that. Because, you know, don't expect that pathology or forensic are the one who moved, because there is a problem of money rewarding. I mean, you need to identify some center, specialized center, because you don't need a cardiovascular expert, pathology expert everywhere. Fortunately, sudden death is not so frequent. Aborted sudden death is increasing, fortunately. But when a case like this, particularly under the age of 40, I would say under the age of 50 is occurring, really you need to perform an autopsy and to have an expert for a revision. This is what is important. But pathology and forensic will follow this if there is a request from the clinician. So there is a need of a request from the clinician for expert pathology. Otherwise, there is no possibility.
Do you think, I mean, talking about these reference centers, I know that in the UK, and probably you have also something similar in Italy, you get the hearts of so you become a referral center and you don't need to do get the whole package.
No. Of course, it's not. I mean, it's not possible to say all the autopsies sudden death in a country are performed in a place. This is obvious. I mean, the general autopsy should be performed locally. And then when you exclude the cerebral hemorrhage, you exclude other story, you send the heart for the expert examination if there is no local pathologist looking for. This is the question. It's like for biopsy, we are not sending the living patient to a place where there is biopsy. When biopsy is needed, you send the biopsy to a referral center. But same is for MRI. Probably not the MRI center are the same level. So probably you should identify some place where you can have an expert opinion. Digital pathology can be of help, for sure. Digital pathology, because you can have a gross picture, but then slides reviewed by expert center could be one solution.
Okay, I have one question. Bo, this patient wants to do sports and at a super high level, like really high level, where the fact of having an ICD is not a problem. What would you suggest?
So what was the the patient? Was it an idiopathic VF patient?
Yes, no, the one that Andrea presented.
Okay, yeah. So if we are having idiopathic VF patients and they are genetically screened and they are not having any genetic mutations in the ryanodin receptor genes or LongQT genes, and they do not have any structural heart disease, I would not put them in any restrictions. Also, not when it comes to sports. No. Obviously, if you are having a patient that keeps getting ventricular arrhythmias during sports, is another thing.
Yeah.
But up front, and that is very important. I think that we should be very careful not to restrict our patients too much in doing exercise. But of course, there will be some diseases where it's maybe not advisable, obviously. But for this particular patient, I hope, Andrea, that he's back on the pitch, even though it was during sports.
Yeah.
I think it's very important. Yeah.
Okay. So overall, and I think we should start closing our session. I think that we have had a nice discussion on those cases that really are the doubts, and I think the case was the example on when nothing comes out. But of course, to say that we have nothing, we have to look for everything. We have to really be to perform a comprehensive analysis at all points: genetic, pathological, of course, the screening and family screening as well. So I think this is the idea we should keep at the end of the day of how important it is to have things done in an appropriate and protocolized way in order to make sure that we don't skip any detail, right? So Elena, if you want to close up.
Just to congratulate all of you. I think all of the presentations have been very interesting. The case was fantastic. Christina, I'm always amazed by the amazing pictures and how good you are on what you do. And both the three aspects, the major aspect that you covered, which is preventing sudden cardiac arrest and having good outcomes. I think you're doing fantastic job in your country, and I think we could copy this throughout Europe and throughout the year. And so thank you very much. So with that, I think everybody would like to have a great evening, right?
Thank you very much.
Great.
You all.
So see you
Thank you.
soon.
Bye.
Thank you.
Bye.
Thank you, Ninke.
Bye.
Bye-bye.
Bye.
Thanks
Bye.
at all.
Yeah, thank you, Ninke.